Good evening, everyone. Welcome back to another session of the Conceptual Surgery Live Connect. Today, we have a very important topic to discuss, which is pancreatitis. Before we get into it, please allow me to introduce myself. I am Dr. Adiba Nizam. Currently, I am working as a senior resident at Adiba Medical College. I have completed my MS and DNB from Maulana Azad Medical College and have also worked there as a senior resident. Okay. Getting back to a topic of acute pancreatitis. First, let us discuss why this topic is an important topic for us as postgraduate students in surgery. As you all know, since the day you would have joined in surgery as a resident and done your first emergencies, acute pancreatitis is one of the most common cases that we will be admitting for wards, especially with gallstone-induced pancreatitis and severe necrotizing pancreatitis. So it's a very common case that we see on a day-to-day basis. Then again, when we talk about our exams, it's also a very common question that is going to be asked in the exam, usually on the lines of the management of acute pancreatitis or the severity assessment in acute pancreatitis. Now, as the name implies, acute pancreatitis, it's an acute inflammation of the pancreas which leads to the injury or destruction of the acinar components, the exocrine components of the pancreas. We have a very diverse clinical spectrum in acute pancreatitis, implying that the severity of pancreatitis ranges from a very mild disease to a very severe form of disease, which can be life-threatening. As you will see, as we progress with the lecture, we'll be classifying pancreatitis on the basis of severity into mild and severe pancreatitis, with the spectrum being so diverse that some patients would improve with just a conservative management with a very little mortality of as low as 1%, whereas in severe pancreatitis, we can see mortality rates ranging up to 50%. Usually it's in the range of 20 to 30%, but up to 50% mortality can be seen when we are dealing with patients of severe pancreatitis. Now, moving on, in this lecture, we'll be covering the etiology of acute pancreatitis, the pathogenesis, the pathophysiology, then what is the clinical presentation of pancreatitis. We are going to attempt to classify pancreatitis based on its severity. Then we'll be discussing the management of acute pancreatitis. So, first of all, coming on to the etiology. So, most of the cases that you will encounter will be of two main causes, which are alcohol and gallstones. Of these two, gallstones are the more common. Up to 60 to 70% of the cases of acute pancreatitis are caused by gallstones. The remaining 20 to 35% because of the use of alcohol. However, there are other causes that we need to keep in mind, where and there is a list for this. We have to discuss some metabolic causes such as hypercalcemia and hypertriglyceridemia. In hypertriglyceridemia, we are talking about the familial hypertriglyceridemia, usually types 1, 4, and 5. And when we are talking about hypertriglyceridemia as a cause of pancreatitis, the levels of triglycerides are usually more than 1,000. More than 1,000 is suspicious for hypertriglyceridemia-induced pancreatitis, whereas more than 2,000 is confirmatory diagnostic for hypertriglyceridemia-induced pancreatitis. Then we have certain drugs which can cause pancreatitis. It's a very long list. I have mentioned very few of these. Then we have infections, which could be bacterial or viral infections. Then, as a result of instrumentation, as in ERCP, then it could be because of post-surgical also, then because of trauma, organ transplantation, and as a form of hereditary pancreatitis also. Hereditary pancreatitis occurs as a recurrent pancreatitis. So it's a recurrent acute pancreatitis that we will encounter in hereditary cases. Moving on to the pathophysiology of pancreatitis. As we know, acute pancreatitis happens when the enzymes, the proenzymes we have enzymes in the pancreas that are required for digestion of the ingested food, the digestion of the ingested fat that we are ingesting, And of the fats and proteins, we have trypsin, which is stored in the pancreas in the form of trypsinogen in its proenzyme form. If it is activated inside the pancreatic acinar cells, it causes damage to the pancreatic acinar cells, leading to a cascade of inflammation, which causes local and systemic inflammation, leading on to all the clinical manifestations of pancreatitis. So, we have some causes which will incite the initiating mechanism of premature activation of the proenzymes into the active enzymes while they are still in the pancreas, leading on to pancreatic injury, leading on to release of further chemokines, cytokines, producing local and systemic effects. So here, as you see, we have multiple causes like a pancreatic duct obstruction or a reflux of infected bile, hyperstimulation of the pancreas by toxins such as alcohol and triglycerides, and leading to proenzyme activation and pancreatitis. Here we see, I would like you to note that these chemokines and the cytokines that are being released, they are causing both a local response, which is because of inflammation and ischemia. The pancreas is getting inflamed, and also these cytokines are eliciting a systemic response, which we'll see later on. So then again, here we have a description of the main description of the cytokines that are being involved. We have the TNF alpha and the IL-1, which lead on to the starting of this inflammatory cascade, which also involves the IL-2, IL-6, IL-8, IL-10 bradykinin, leading on to a systemic inflammatory response and a multi-organ dysfunction, if uncontrolled, which may also lead to death and mortality. Okay, so here we have divided acute pancreatitis into, we have two phases for it, an early phase and late phase. In the early phase, which is usually the first, the mortality that happens is because of the systemic inflammatory response and the multiple organ dysfunction. Whereas in the late phase, which is after the first week, the mortality is usually because of septic complications, where the patient develops sepsis and further on septic complications, which are responsible for mortality. Then further, in acute pancreatitis, we have this severity grading. There are many systems that are used. Here, this description that I'm giving is from the Atlanta, revised Atlanta classification 2012. Severity there is classified in 3, which is mild, moderately severe, and severe. And further on in the Atlanta classification only, we have 2 types of pancreatitis, which is the edematous pancreatitis and the necrotizing acute pancreatitis. And further on, Atlanta also classifies complications as the peripancreatic collections. If less than 4 weeks, if more than 4 weeks, it will be called as pseudocyst. Similarly, necrotizing, less than 4 weeks, an acute necrotic collection, and more than 4 weeks, it will be called a walled off necrosis. This is a description based on Atlanta. We will be discussing other severity systems also. How Atlanta has classified acute pancreatitis. Coming on to the clinical presentation. Acute pancreatitis has a typical pain. This pain starts in the usually in the upper abdomen, in the epigastric region, and it reaches its intensity in a matter of minutes rather than hours, and it is constant and unrepeated. Even with the usual dose of analgesic, this pain will not relieve. Having achieved its intensity within the first few minutes, this pain is usually radiates to the back, and the patient feels that it worsens when he lies down and would be better if he leans forward. Okay? And usually this pain would be associated with episodes of vomiting and nausea. In patients who are presenting with severe pancreatitis, we may have further problems such as the patient might come in shock, the patient might have respiratory distress, might have abdomen which resembles which is a rigid abdomen which resembles a perforation.